The Diabetes Nerd podcast is proud to be sponsored by the Eversense 365-day implantable continuous glucose monitor brought to you by Essentia Diabetes Care. I've been using the Eversense CGM since April of 2025, and I love it. It's the only CGM device that lasts a year. The sensor was placed just under the skin on my arm. The transmitter sits on my skin with this silicone adhesive, and I can take it on and off. I love it. Learn more about Eversense 365 at eversensecgm.com. Welcome to the Diabetes Nerd podcast. I am your host, Ginger Vieira. I've lived with type 1 diabetes for about 25 years, since 1999. And with me today is Dr. Camille E. Powe, who is a brilliant and very passionate clinician focused on diabetes and pregnancy. Dr. Powe, please give us your whole background and credentials and all the things that make you who you are.
Great. Well, thank you so much, Ginger, for having me on to discuss my favorite topic, which of course is diabetes and pregnancy. So I am an adult endocrinologist. I work at Mass General Hospital in Boston, where I co-direct our diabetes and pregnancy program, which is something I founded about 8 years ago now. And we take care of pregnant individuals. We partner with them to help manage their diabetes during pregnancy, and we have maternal fetal medicine specialists, endocrinologists, nutritionists, all working together to help people on that journey. And then I also do a lot of clinical research so that we can advance the field and make sure that pregnant and lactating individuals are able to benefit from all the amazing technologies, therapeutics that have been developed for diabetes over the past 10 years and beyond.
Okay, so that program you developed is serving women with type 1, gestational, and type 2?
Yes, absolutely. All of
Okay.
them, all of the above, and even rarer forms of diabetes like MODY. So,
Okay. And that must, how many times a year do you get a patient pregnant and who also has MODY? Is that really, really rare?
several times a year, yes.
Several? Okay.
Yeah.
On one hand, you can count this out. Okay.
But we've been doing
Okay.
it for a while, so now we've accumulated quite a lot of experience with it. So,
Yes, yes. So, the first thing so many of us who've lived with type 1 diabetes for decades think of, and I feel like I was diagnosed kind of when they stopped saying this to young girls, but I feel like right before me, like maybe even just within the decade before me, they would tell your parents, she really probably shouldn't ever have babies, right?
mhm.
And unfortunately, so much of the textbook stuff is still based on that old data, right?
Yeah.
How dangerous it is for mother and baby. And then we've got Julia Roberts in that movie. And
Yes, I knew you were going to
right.
bring that up.
Yeah, you can't not. We have to acknowledge it because it's just so terrible, right? Of what it says this journey is going to be like for you. Can you just talk about how things have evolved and
Totally.
in reality today?
Totally. Well, this is honestly amazing because before insulin, right, 1921, when insulin was first given to people for type 1 diabetes, it was really dangerous for both mother and baby to be pregnant. But we've come so far in the past 100 years, not only for type 1 diabetes in general, but also for pregnant women with
Even just the
diabetes.
past 30 years.
Exactly.
Yeah.
Yes. So it's really different now. We do have the tools to help people with diabetes have healthy pregnancies and healthy babies today. I wish we had more tools because, unfortunately, in general, in clinical research and medical therapeutic and device development, historically, pregnant and lactating women have been left out of sort of those innovations and that research in order, with good intentions, to protect them. But the
Yes.
downstream consequences are that it takes so much longer to
Yeah.
get pregnant individuals these advances. And in diabetes and pregnancy, this is a time when they need those tools the most.
Yeah, it's such a
And
catch-22 because you don't want to
right,
experiment on the woman and her baby. But yeah.
but unintended consequences. And we know
Yeah.
that there are responsible ways to do research in pregnant women. And, that's what I've dedicated my life to doing.
Yes,
So
thank you.
obviously I feel some kind of way about it. But that said, I do think there are real unintended consequences of leaving pregnant individuals out of clinical research. And one of them is that the tools aren't available, people don't have the data around them. Many clinical providers are scared when it comes to pregnant women. What do I do with this person? Can they really
Mm,
use this new device or technology? Is it going to hurt their baby? Am I
yeah.
going to be liable for that? And that really leaves pregnant people in a tight spot,
Yes.
because we don't have necessarily the guidance and the evidence base to make firm recommendations that can be disseminated to all clinicians,
Yeah.
so that you don't have to just be in the know
Yeah.
in
I
order
so
to
like
do
what
this well.
I think of a few things. The first is just automated insulin pump technology.
Yes,
My co-author Jenny Smith of our Pregnancy with Type 1 guide, she
love that book.
thank you. She explains in it that there's going to be times, especially in the last trimester, where you're probably going to want to turn off that automated system because it isn't designed to match what diabetes management is like during pregnancy and that really slow digestion and just all the things that intense insulin resistance that we meet in that last trimester.
Yeah,
How do you, yeah,
absolutely. These systems, at least the ones that we have available today in the United States that have been cleared by the FDA and are available, widely available, there's new ones coming out, but are not designed to meet pregnancy targets. In fact, if you are in sort of an ideal range for pregnancy or predicted to be in an ideal range in terms of your blood sugar number, say your blood sugar is between 80 and 100, most of the systems will turn down the insulin delivery if your
yeah,
blood sugar is in that range. So then
yeah,
you are kind of fighting with the system.
yeah.
At the same time, we know these technologies are so important. We
Mm-hmm.
know that they really help people, they ease the burden of living with the disease, and they've been an amazing revolution.
Yeah,
But now you've got a situation where you're fighting with this technology.
yeah.
And the question is it better to have it on and fight with it, or do you turn it off?
And go manual.
And
Yeah.
I think people can make individual decisions. There's a lot of there's doctors and other CDEs, et cetera, that have expertise that can sort of help you through that journey.
Yeah.
But the the reality is we actually don't have great evidence in medical research studies to like tell us what
To
the
have a solid
answer should
opinion.
be. Right,
Yeah.
exactly.
Right. Right.
And so actually I'm involved in a study right now called T1D Pregnancy and Me that we're doing with the Jabe Center, uh, the uh, the Jabe Center, and it's funded by the Helmsley Charitable Trust, which is a direct to participant study where we are asking people with T1D to partner with us who are pregnant and let us go on that journey with them, tell us about their experiences through online surveys, and share their device data with us to get so that we can deliver answers to these questions to the
Yeah.
medical community and to people living with T1D. So we we're really excited about that opportunity to be able uh, to
Yeah.
potentially
Collect
get
that
these
data.
answers that people need.
Cool. Okay. So one thing I wish I had when I was pregnant, and it came out I think kind of right after my second pregnancy, was inhaled insulin, which I use today all the time. But I think back and I'm like, man, that would have been so helpful during pregnancy for popping those highs or rising numbers down so quickly. Are you allowed to express your thoughts on? I know it's
On
obviously
inhaled
not
insulin? That's a
FDA
good
approved
question.
during pregnancy.
This is a hot topic, right?
Mm-hmm.
So, one of the issues, just for people listening in pregnancy, is that we're trying to do this really tight, intensive glycemic management, especially the after meal blood sugar. And one of the main problems is that our insulins are too slow. I mean, that's a problem in general.
Right.
Subcutaneous insulin is too slow, but especially in pregnancy where we're trying to get the glucose to these really tight targets after eating. It's just too slow. It frustrates me every single day. Like, seriously.
This keeps you up at night,
So
I can tell.
inhaled insulin is faster. That's like one of the really awesome things about it. Um, and so there's a lot of interest in whether this can be used in pregnancy. There's some ongoing study that I know about looking first in gestational diabetes and trying to really build that safety profile to show whether it's safe, because I think the main concern is about uh, pulmonary. But when you're pregnant, there are changes in your physiology, in your lung physiology, in your breathing, in your respirations, right?
Mm.
So we want to make sure, and by we, I mean like the medical community wants to make sure that in the context of those pregnancy changes in breathing and lung physiology, that there's nothing unexpected with regard to pulmonary issues with inhaled insulin. And so that's what these investigators are trying to do to show first in gestational diabetes. And then I think, hopefully it will be a great therapeutic option. I
Yeah.
think one of the challenges, and not, I haven't, uh, I've seen you talk about your experience with inhaled insulin, is, in pregnancy, you need these very large insulin doses many
Mm-hmm.
times. So I think also another thing that we want to work out is whether you'll be able to inhale enough insulin to really help
Yeah.
with the,
I mean, I
in the third
personally,
trimester.
yeah, I personally, just even as a non pregnant person, if I were to eat a slow digesting meal, I would never depend just on inhaled
Just on it.
insulin to
Yes.
cover that, right? Because we do need the really slow stuff too. And it's very helpful also when you're pregnant and it's so slow. I mean, for anybody listening who's never managed diabetes when you're pregnant, like the 15-minute pre-bolus in the third trimester becomes like a 45-minute
Mm-hmm.
pre-bolus of taking your insulin and waiting and then eating. And that slow stuff is important, but it's that combo. I just think it would be so amazing to have both of those tools when you're trying to stay between 70 and 140 all day.
Yeah, totally. And
Yeah.
I'm really excited that that study is being done so that hopefully we can have as many therapeutic options as
Cool.
possible
I'm glad to
for
hear that's
pregnant people.
happening and that,
Yeah.
okay, and it's bit by bit. And it's always so much slower than we all want it to be, but bit by bit for sure. Okay. So, and I know this is an impossible question, but I'm going to ask it anyway. What is one thing that you really want women to know about pregnancy with type 1 diabetes before they conceive?
So I think the main thing that I want people to know is that while the targets for blood sugar, the blood sugar goals, are really tight, they're really intensive.
Mm-hmm.
I get this reaction
Intimidating.
all the time when I tell people, I do preconception consults, so I meet with people before when they're thinking about getting pregnant. Some
Mm.
have even asked me, should I get pregnant? Should I have a surrogate? And so I, I'm in this position of telling people, and some people, when I tell them the goals, they look at me like I'm crazy. I mean, if you live with this disease every day, it sounds crazy
Yeah.
sometimes. what
Yeah.
these goals, we want to keep your blood sugar in this tight range. We want to keep it less than 140. And I guess what I would tell people is that it's a marathon, not a sprint. In that, yes, this is a short period of time. Yes, it really matters. But everyone, when they're pregnant, is going to have a blood sugar of 200.
Yes.
It happens to everyone.
Yeah.
And it's not about, people get so anxious in that
Yes.
moment.
I get those messages in my
Yes,
DMs. Ginger, I'm 6 months pregnant. My blood sugar was 200 yesterday. Is the baby okay? I mean, I literally get those
right.
messages. Yeah.
And it's going to happen. So this is about what we can do together on this journey across your whole pregnancy. And these are challenging goals. I want everybody to have people on their team that can help guide them and work with them through this. But again, it's a marathon, not a sprint. It's about the total big picture. It's not about any one individual bad day or bad blood sugar or
Right.
bad
And
blood sugar.
that I had for my first pregnancy, I didn't go to an MFM team, maternal fetal medicine. For anyone listening, that's the OB team that works with women who have more complicated pregnancies. And I thought, well, I'm really healthy. I don't need to be in the sick people OB team, right? And I know this is a common thing that I've encountered with other people. And I put it in the book too, of being like, listen, there's the other reason I might not have needed all that extra hand holding, but what I needed was people that understood I didn't need all the extra hand holding. So I was going to this OB team that only knew gestational. And
Mm,
my A1C at this point was like 5.3 or something. And I didn't stay down that low very long. But just for context, my A1C was that low, right? They look at my data on my printout thing, and this is now nearly 11 years ago. So CGMs were still very new. And I had a blood sugar post meal of like 165. And the clinician was like, 165, that's too high. I was like, I know. Like, I know that's not the goal, but like, I need the 165 is what tells me, okay, time to boost my basal or time to boost how
hmm
I dose for meals. And they understood so little about type 1 that they
Yes,
didn't understand like how hard I was working in order to have an A1C in the low fives. And that,
right,
like, yeah, a blood sugar of 165 is gonna happen because that's the only way I know I need more insulin. I can't anticipate that, 'cause then I'm just gonna risk being low all the time. You know, it was like it was
right.
very upsetting, and I did not go there for my second
Yeah, I
pregnancy.
can understand that. And I can also understand, you know, if you don't have that team that really understands what it's like living with type 1 diabetes. Everyone with type 1 diabetes knows that your blood sugar is going to sometimes be
Yeah, I mean,
165.
there's
In
just
fact,
no
that's really
way.
great, honestly.
Yeah,
We are shooting for these aspirational goals in pregnancy, and they are really hard to achieve, and
mm-hmm.
you really need someone in your corner who
Yeah,
understands that,
how
and
hard you're
also
working.
again isn't going to look at any one individual blood sugar, is going to help you see the bigger picture.
Yeah,
Because what happens is if you get trapped in an individual blood sugar, what are you going to do? You're going to rage bullets, right?
yeah, and be in
then
a
you're going to end
nine-month panic
then
attack.
you're going to end up low. Then you're
Yeah,
going to end up high again. You're going to be on that roller
terrible,
coaster. And it's
terrible.
my job to get you off the roller coaster, right? So
Yeah,
I think that's why I really like people to step back and see the big picture. And I really
yeah,
like to go over people's numbers with them. And yeah, we talk about the targets. And but you'd be so surprised how um without that bigger picture, just living it day to day, people actually don't have an accurate representation of like how things are going and whether they're meeting the targets, because if you're not looking at that summary data, and many people do but many people don't, you're
right.
just in it in the moment and dealing with
Yeah,
the anxiety and the ups and downs, and you
yeah.
don't realize, well, actually, you're 80% time
You're
in the
doing a
pregnancy
great
target
job.
range.
Yeah,
That's
yeah,
amazing. Like it's,
yeah,
and the goal is 70% in that target range of 63 to 140. It's not
yeah.
100%, right? Like, of course, we're going to try to get your your blood sugars as optimal as we can to get you there. But again, it's the big picture. It's not any one day. It's sort of a journey. And I love going on that journey with people.
Man, if only we could clone you, that would be really great. That just that passion and commitment and compassion, right? That you have for how hard your patients are working. One thing that really helped me before my first pregnancy is, which I had lots of time to plan ahead for. We weren't married yet, and so it was like we knew we were going to start trying as soon as we were married, and I practiced managing my blood sugar as though I was pregnant
Well,
for 6 months. And now looking back, it was nothing like when I was actually pregnant, right? But it was just to show myself, like, hey, you can actually
hmm
do this. And again, that was my first time using a CGM as well. So I was learning so much about tighter blood sugar management that wasn't possible before without CGM technology safely, right? But that gave me the confidence to be like, okay, I think actually I can do this. And the other thing was I simply looked around, mostly on the internet at the time, of the women who were blogging about their pregnancies, and I was like,
hmm
if they can do it, I can do it. And that's how I work through a lot of things. Like I recently started waitressing recently, and I was just like, and it'd been 12 years since I waitressed. And I was like, can I really do this anymore? And I look around restaurants and I'm like, if they can do it, I can do it. So just use that same, this can't be that hard. And pregnancy management is very challenging, but all these women are doing it.
Yeah, absolutely. And I
Yeah.
wish, I think that I wish that we could fully leverage the tools that are out there. And
Mm,
I think, that gets back to this issue of not having the tools be designed around the needs of pregnant women
mm-hmm.
from the get-go, because it's always going to be challenging, I think, but it could be so much less challenging if we were able to leverage everything that we have at our disposal.
Is there I know when Jenny and I just simply went to write the pregnancy book, we approached some of the larger diabetes orgs and said, would you like to publish this with us, right? And you'd think they'd be like, oh my gosh, there's no such thing as a guide to pregnancy with type 1. Absolutely. But instead, their reaction was, well, that's a very small audience. It's not really worth it for
Mm.
us, right? Is that kind of the mindset in the research world as well?
Well, I have run into that mindset, and I like to remind people that not every woman gets pregnant,
Mm-hmm.
pregnant, but it is experience that 80% of women have a pregnancy before the age of, if you look at 45 or 50-year-old women, 80% of them have
Oh,
had a baby.
of all
And
women, not
so,
just diabetes related, all women.
right, all
Wow.
women.
Okay.
And so, yes, at any given moment, maybe there's fewer pregnant women than there are, women or just people in general.
Mm-hmm.
But it's a pretty common experience.
Yeah.
And people really do, all of us who have kids, view it as a pretty important moment
Mm-hmm.
in our lives, even though, it didn't even last a whole year.
Right.
I really think that people need to have that broader view that this is a not universal, but very common, important human experience that
Yeah.
is important to so many people. And I think that that means people should pay more attention to it.
Yeah. And more women with type 1 are pursuing pregnancy thanks to advancements in
Yes.
technology and medications.
Yes, and we're building that research up, right? So,
Yeah.
many people are passionate about this, and we are, every year we're getting new tools to help us manage diabetes and pregnancy better.
Yeah.
You talk about CGM. I mean, how amazing, how much different
Yeah.
would it have been to manage your pregnancies without
Without a
that tool?
CGM. Yeah. I
Yeah,
mean, it, we'd be aiming for an A1C below 7 safely instead of A1Cs below 6 safely.
right. And the data shows, the concept trial, which was now published, I think almost 8 years ago or about 8 years ago, actually proved, and they did the study in pregnant women to prove that using continuous glucose monitoring not only improves blood sugars in pregnancy, but also improves baby's outcome. So in
Mm,
that study, they showed a much lower risk of the baby having a low blood sugar or going to the neonatal ICU just from
mm,
using a CGM.
right. Yeah. I mean, it's a no-brainer, of course.
Yeah.
Yeah. So another thing I want to bring up and hear you expand upon too is, you know, many women with type 1 are feel very fit and healthy and kind of like, yeah, I have type 1, but that doesn't mean I'm sick, right? That's the mentality I had.
Yeah.
And in my first pregnancy, the only kind of complication I had was that I got norovirus when I was 8 months
Oh,
pregnant, which
oh,
was
that's the worst.
terrible. Yeah, it was
Oh,
terrible, but it was unrelated. You know, it made diabetes complicated. I was in the hospital for like 3 days with the IV
yeah.
because I couldn't even take a bite of a popsicle for 3 days without puking. But it wasn't fun. I lost like 10 pounds in 3 days. And
My
my
goodness.
friends would look at me
Oh,
and be like, oh my God, you need to eat a burger. And I'm like, I swear I am eating. This was like a fluke. But so that was my only troubles during that one. My second pregnancy, this child, she's a wild little creature. So it's not surprising. But around two things happened. Around month 4 or 5, I started producing an insane amount of stomach acid.
mm,
And to the point that it wasn't even heartburn. I was just vomiting. I would fall to my knees. My whole torso was just in so much pain. And it took a lot of demanding that this was real and that antacids, you know, Tums wasn't going to cut it. I was on
yeah.
like double
No.
prescription mega strength, right? So that was rough. But then in the last, to me, it felt like years, but I think it was just like the last month and a half. I started gaining a half a pound of fluid. Maybe at
Wow.
first it was a quarter pound and then a half a pound of fluid in the last month every day in my feet.
Mm,
But I have low blood pressure to start with,
I see.
right? And so my blood pressure was still very much within normal. Like my blood pressure when I'm not pregnant, both numbers can be under 100. That's how low
Mm,
my blood pressure is, right?
mm-hmm,
I had high blood pressure for me, but
mm-hmm.
and I was in tears every day. I'm also raising the 2 year old, right? And my husband
Yeah.
would come home from work and I would just look at him and burst into tears. I just felt like my body was giving everything it had to keeping the baby alive.
Yep.
And looking back, because I did nearly bleed to death a week after she was born, my
My
uterus was not
gosh.
capable of a contraction. We
Oh
didn't
my
know
God.
this. I never had a contraction with the first kid either.
Wow.
And it was just filling with blood clots. I think I was absolutely in preeclampsia.
My
But
goodness.
because on paper I looked normal, it was all kind of dismissed. And I did end up basically begging for an early C section. It wasn't even
Mm,
that early. I was still like 38 weeks. And all the doctors were like, no, we don't want to be told what to do by this type 1 who
mm.
thinks she's, I'd already published that pregnancy book. And that honestly, that makes doctors, some of them, not want to listen to me. I'm not kidding.
Really?
Yes, I'm not kidding. Like, she's not going to come in here and tell us what to do. And I'm sobbing to these people. I'm like, please help me. I know something's wrong. The baby looked happy. There was one doctor who wasn't threatened by me. He was the only male doctor in the clinic. And he said, if her lung fluid is okay, we will do a C-section. And so I ended up having a very calm, peaceful C-section. But I swear, if it had gone on any longer, I would have had an emergency C-section. And so my whole
An
point is,
experience. Yeah.
yeah, it was terrible. It was terrible. Um, and she was born happy as can be. You know, she had no complications. My whole point is that you just don't know until you're pregnant what these new stressors are going to do
Right.
to your health. And just because you are super fit and healthy before pregnancy does
Right.
not mean that your pregnancy is going to be an easy breeze.
Right. Pregnancy is, it changes a lot about your body. It's incredible. I mean, this is one of the reasons I got into pregnancy because how amazing is it that we
Mm,
can grow a whole human and have our whole physiology change, and it's fascinating, right?
It's crazy. My mother
Um,
would tell you that men are so jealous of us since the day they were created because they can't create life. So it's why they do all these other crazy things instead. That's my mother's philosophy.
yeah, but at the same time, it's very different from sort of like your baseline state. So, like,
Hmm.
one example, obviously, that you've experienced is these incredible changes in insulin resistance. Right. I think there's like a lot of stigma around diabetes, which we're all trying to fight against, but like people think of, you know, insulin resistance as this bad thing. And also it's, people really tie it to kind of like lifestyle because it's such like a lifestyle target, right? So people
Hmm.
feel guilty when
Yes.
they have insulin resistance.
Yeah.
And because that those concepts have been tied together in their mind, then they get pregnant. And now the placenta is pumping out all these
Yeah.
hormones that's going to make you insulin resistant.
Yeah. And they
And I
freak
have
out.
people
I
come
get
in my
those messages
office all
too.
the
Yeah.
time saying
Yeah.
like, I, I'm eating, the same as I normally eat, and like I'm exercising. I have pregnant patients running
Yeah.
not marathons, but maybe like running on a
KMs. Yeah.
regular basis,
Yeah.
every day they do that throughout their pregnancy, and they're like, they can't grasp how they could be experiencing insulin resistance. So I have to tell them,
Yeah.
it's not
This
you, it's
is,
nothing you're doing. This is the baby. Babies are
yeah.
sometimes
And
I say
it's a
babies are
sign of a healthy
crazy.
pregnancy. Like, because I
Exactly.
get these messages too, Dr.
Right?
Powe. Poe, sorry, of women being like, my insulin resistance keeps going up, and I don't know why, and I'm so
And I
worried.
want
I'm
to
like,
stop it, right? But it's not,
yes,
it's part of the physiology of pregnancy, right? So
yeah,
you, it, if you haven't been pregnant before, you can't imagine what you might experience. And then, you know, every pregnancy is also different. So unexpected things happen. And so that's why I think you really do want to have a team around you, especially with type 1 diabetes and pregnancy who knows what that's like and
mm-hmm,
also really can clue you into things that are going to happen and give you that anticipatory guidance.
mm-hmm,
Okay, like your 20 weeks gestation, like in the next couple weeks, you're going to start feeling like, wow, I'm needing more insulin, right?
mm-hmm.
And you're
And
not
then
crazy, you're
it's
not
gonna
going
keep
crazy,
going. Yeah,
right?
you're not doing something wrong.
Like
Yeah,
it's nice to be able to hear those messages and
yeah,
also to have people around who have seen a lot and kind of can pick up some of those early warning signs that like you were talking about that you experienced in
mm-hmm.
your pregnancy, because uh, that may be the difference between a good outcome and a bad outcome, right?
Yeah, I mean the preeclampsia, like my feet were so swollen, I could not even barely fit in Crocs.
Mm.
None of my shoes fit. My skin was bursting and burning because it was being stretched so much on my feet. I could barely go up and down the stairs because my ankles wouldn't bend. Like it was brutal, and this was with the MFM team. I don't know why they couldn't see this, but it was it's only because I just kept yapping and speaking up.
And people should advocate for themselves. When
Yeah.
you have type 1 diabetes, you're very in tune with your body to
Yes.
an extent
Yeah.
that a lot of people who don't live with this disease aren't.
Right.
And
And you
so,
can't explain that to some doctors feel so threatened by being told what to do when I'm really just I can just feel that something is so wrong, you
mhm.
know? But and
Yeah,
also just on the note of preeclampsia, technically I was so healthy on paper, and we're taught that preeclampsia, your risk of preeclampsia goes up if your diabetes is not well managed, if you're not eating healthy foods, if you're not exercising. Well, I was doing all those things,
yeah,
and yet I still was absolutely experiencing preeclampsia.
yeah. And that's the thing that can sort of happen in pregnancy. Yeah, like we can talk about risk factors for certain
Mm-hmm.
pregnancy complications, but everyone who's taken care of pregnant women have seen those conditions emerge in people with no risk factors.
Mm.
Absolutely, I see people with no risk factors get gestational diabetes. all
Right.
the time.
Yeah.
That happens all the time.
Yeah.
And,
How
you know,
many of them? How many of them actually might be in early type 1 diabetes? Because I
well,
interview those
I've
people.
seen that too. Yeah, I've
Yeah,
absolutely seen that too. I've
but
diagnosed
not
type 1
always.
diabetes
Yeah.
in pregnancy more than,
Yeah.
more than once.
Mm.
So, and that can be tough in the beginning of pregnancy too, because some of the symptoms can mimic some of the pregnancy symptoms.
Yeah.
And so, I think having awareness around this is important. But I think, my philosophy is sort of that this, being a doctor and part of someone's healthcare team, number one, it's a privilege. Secondly, it is a partnership. It's not the doctor telling the person
Yeah.
what to do, right? Like this is
Yeah.
a discussion. This is like I have a certain amount of I have some knowledge, some expertise that I want to share with you. And then it's a discussion about how do you want to take that information and incorporate it into like your care plan that we're going to develop together, right?
Yeah.
So I think, uh, I'm not an obstetrician, I'm not an MFM, but I think delivery timing is one of those discussions that people can have with their doctors about, when it makes sense for the baby to be delivered.
Yeah. Okay. Yeah. So it's, I mean, really, if your team isn't treating you like you're part of the team and you get to also be part of the decision making, you don't feel heard. I mean, I didn't have another team I could go to, but I did handle it by just continuing to be very vocal.
Which is important, yeah.
Yeah, but which can be really hard for some people. It's not really
Yeah.
that hard for me, but it can be hard for some people. Yeah.
Yeah.
Cool. Well, okay. So, closing thoughts. If there is one thing you want to let women with any type of diabetes know about their pregnancy journey, what would you
Yeah.
tell them?
So again, I think people do a lot of guilt and self-blame in pregnancy, whether they have diabetes or
Mm,
not. So I like to remind people it's not their fault they have diabetes,
mm,
that we're all doing the best we can, that it is really true that blood sugar matters in pregnancy. It really does matter. But that doesn't mean it's your fault, right? Like,
yeah.
and and I like the message that you gave, which is like, I can do this, right?
Mm,
Like I can manage these blood sugars, and and to try to do that without self-blame is
yeah.
difficult, but if you can do that, you actually achieve better
Right.
outcomes in the
See
end.
it as a
If you can do
project
it.
instead of this pressure and guilt and shame and yeah.
Yeah, absolutely. And then the other thing I want to say is because, like I'm so passionate about this issue of pregnant women not being able to take advantage of the advances, is if you're curious, like get involved in research studies,
Mm.
partner to, you know, to make the knowledge available for the next person.
And what's the pregnancy study that's going on that you're helping manage right now? Is that virtual or do they have to live in Boston?
Yeah, what's great about it is it's virtual and you can live anywhere in the United States, including Hawaii, Alaska, and Puerto Rico.
Wow.
So it's for anyone living in the United States with type 1 diabetes who are pregnant. We want to get people near the beginning of their pregnancy journey. So you have to be less than 15 weeks. And if you decide to join, we can help you figure that out. And the
Okay.
best way to get information would be to email T1D pregnancy at jaeb.org. That's the JABE Center, our coordinating center. And we can also share with you, Ginger, a link to the enrollment website where
Okay.
you can join the study. So it's the
And it was
T1D
called
pregnancy,
pregnancy, T1D pregnancy
T1D
and me.
pregnancy and me.
Okay.
Um, and it's all about telling us about your experience with T1D and pregnancy, how you're managing your diabetes during pregnancy, what are you doing? Forget what
Mm.
somebody told you to do. What are you actually
Oh, what are you
doing?
actually doing? I love that. Yeah.
Sharing. You don't have to be using a pump. You don't have to be using automated insulin delivery to be in the study. You can be using injections. You do have to be using a CGM, but I would say,
Yeah.
that's probably a good decision for you
Yeah.
anyway if you're pregnant with type 1
Yeah.
diabetes. So we ask you to share your CGM data, and then you do get some uh, compensation for your time for being in the
Okay.
study as well. So it can be done from anywhere, and we'd love to partner with you.
Well, thank you so much for not just your expertise, but your compassion for your patients and spreading that compassion, I'm sure, to every clinician that will listen. So we
Absolutely.
need you and we appreciate you.
Absolutely. Thank you so much for having me on. Again, this is my favorite topic. Diabetes and pregnancy is my
I can
absolute
tell.
favorite topic.
Yeah.
So, anyone who's out there, you're not alone, and you can do this. And I'm so happy for you and everything that you're going to be able to do on your pregnancy journey if you're listening and you're pregnant.
Thank you.